Hello again, guys. So, good day to everyone. Today, we are going to talk about angina pectoris and myocardial infarction. So, these two go hand in hand together because myocardial infarction is a huge possibility for patients who are experiencing angina pectoris. And we will explain why in this lesson. So we'll start out with angina. It's a clinical syndrome usually characterized by episodes of pain or pressure in the anterior chest. So when we say anterior chest, most especially here on the left side of the chest that is affected. And the usual cause of angina pectoris is that there is insufficient coronary blood flow, which results in the imbalance between oxygen supply and demand. If you can recall our previous topic, which is atherosclerosis, that can bring about angina pectoris because of the impeded or obstructed blood flow in the coronary arteries. That's why chest pain is being felt by our patients. Now, the pathophysical factors that increase oxygen demand of the heart or decreases blood flow to the heart will cause altered oxygen supply and demand to of the heart. And if that happens, myocardial ischemia will occur. So there's limited blood flow to the myocardium, which will decrease coronary tissue perfusion, of course, of oxygen. Oxygen and carbon dioxide exchange do not occur because of that blocked or impeded blood flow. Ischemic cells shift into anaerobic metabolism. So they will utilize other ways to create energy in order for them to metabolize, use up glucose, for example, since oxygen is not being delivered to the coronary tissue or to the myocardium rather. And if that happens, there will be accumulation of lactic acid, which will further irritate the nerve endings, causing now chest pain or angina to occur. So that is what is happening with angina pectoris. Chest pain is the major complaint of our patients who are suffering from angina. Now we have the patterns of angina or types of angina pectoris. We have first the silent angina. They have objective signs and symptoms, but the patient reports no symptoms. So with silent angina, if they will undergo ECG, for example, they will, or the results of their ECG will show that they are experiencing angina, but the patient doesn't feel any chest pain at all. Next, we go to stable angina. This is paroxysmal chest pain. It is caused by a predictable degree of exertion, wherein there is a stable pattern of onset, duration, severity, and relieving factor. So it's predictable. That's why it's known as stable angina. We can predict when this type of angina will occur. There's a stable pattern of onset. So we know when it will begin, how long the signs and symptoms are going to last, and how severe it is, and how it is being relieved. Now, for unstable angina, it's also known as pre-infarction, the crescendo angina, intermittent coronary syndrome. You don't know when the angina or the patient doesn't know when the chest pain is going to occur. So there's paroxysmal chest pain in this patient. And like what I've said, it's unpredictable. The patient doesn't know when it's going to come. And usually it occurs at night. That's why it's termed as paroxysmal chest pain. And there's unstable pattern with increased number, duration, and severity over time. So as as the patient goes through with a certain cardiovascular disease and experiencing, and the patient is experiencing angina, these types of chest pain will increase in number. They will be longer as time will pass by, and it will be more severe. It will lead further to myocardial infarction, which is the end result of angina. That's why it's known as pre-infarction. It's unpredictable. Next, we go to variant or Prince Metal's angina. This occurs when the patient is at rest. Unlike that of stable and unstable angina, or most specifically stable, if the patient has exerted an effort, they are going to experience angina. But for this patient, if the patient is at rest, the patient tends to feel chest pain. And the attacks, they tend to happen in the early hours of the day, usually at around 12 midnight to 8 a.m. So that's variant or Prince Metal angina. Next, we go to nocturnal angina. It's associated with rapid eye movement or REM, sleep during dreaming. That's why it's known as nocturnal angina because this occurs while the patient is dreaming, while the patient is having rapid eye movement. Next, we go to angina decubitus. There is paroxysmal chest pain that occurs when the client reclines and lessens when the client sits or stands up. So it's similar, quite similar to um, what is happening in orthostatic hypotension because the angina of the patient usually they will occur when the patient is lying down, but it disappears when the patient sits up or stands up. Similar to that of orthostatic hypotension, it's with regards to the posturing or the positioning of the patient. Next, we go to intractable angina, chronic incapacitating angina, which is unresponsive to interventions. So if you gave medications to the patient and the patient is not relieved from the medication, this is intractable angina. And we also have post-infarction angina. It occurs after MI when residual ischemia may cause episodes of angina. So it occurs after the patient has undergone myocardial infarction. That's why it's known as post-infarction angina. Now we go to the clinical manifestations. First is there's transient paroxysmal attacking of substernal or precordial pain. Precordium is here. It's the area on the chest that is above the heart. The onset can either be quickly or slowly. The location, it's retrosternal or slightly to the left of the sternum. So that's what I've said. It's in the left area of our chest. It can be at the back of the sternum or slightly at the left of the sternum. Radiation, the pain is going to radiate to the left shoulder, left arm, neck, and the jaw. So it will come up to the jaw of the patient. Duration may be around 10 to 15 minutes, but maybe more than 20 minutes, but it should not exceed 30 minutes. Because if it exceeded 30 minutes, that's a different discussion. That's already under myocardial infarction. The patient may be suffering from it now. Sensation, it's either the patient is going to feel squeezing, burning, pressing, choking, aching pain, or feeling of gas, heartburn, or indigestion. Sometimes the patient is going to feel that something is bearing down on their chest. There's a pressure that is bearing down on it. Severity can be mild to moderate. And the drug of choice of patients who are suffering from angina is nitroglycerine. It's relieved by this drug. It's a potent vasodilator. So it causes the constricted arteries to dilate in order for blood to flow through it. And this one is, or angina is further aggravated by activity. That's why for patients who are experiencing angina, they should rest. Okay? And here, exertion will lead to pain. If they rest, they will experience relief. So this will become a pattern later on. If the patient is suffering, let's say, for example, from atherosclerosis. So here are some photos that can, like exercise, proper diet is very, very important. And Anger management as well, because stress can also contribute to the development of heart disease. So, in order to prevent the occurrence of heart disease, proper diet should be done. You should avoid foods that are high in saturated fat. You go for the good fat, the polyunsaturated or the unsaturated fat. And of course, practice daily exercise, at least 30 minutes per day. 30 minutes. That's all that we ask from you guys. 30 minutes per day is enough in order for us to be saved from having a heart disease. So this nitroglycerin, this is the drug of choice for patients who are suffering from angina. So chest pain, like what I've said, there is this can be sudden or this can be slow with its progression. So this is the referred pain or the radiation of the pain from the chest resulting from angina, like what I mentioned to you earlier. So it can come up to the left jaw until the left arm, even the hand. So if it's more than 30 minutes, that's no longer angina. It's already MI. So it should not be longer than this. Other signs would be dyspnea, of course, and palpitations, pallor and sweating, dizziness, fainting can occur, digestive disturbances can occur as well. So here are patients who are suffering from that. Diagnostics, ECG is going to be done. So the doctor is going to do the reading of the patient's ECG, or some trained nurses. You can be trained as well later on as you are already registered nurses. Exercise electrocardiography or stress test is going to be done as well to test for the capability of the patient to do strenuous activities. Radioisotope imaging to check, together with coronary angiography, to check for the area of ischemia or the area that is having that blockage in the coronary arteries. That is very, very important for the doctors to learn. Now, medications. Opioid analgesics, most specifically morphine sulfate, is given to patients who are suffering from angina pectoris. Even those patients who are suffering from MI, morphine is given to relieve the pain. Together with nitroglycerine, morphine sulfate can also cause vasodilation in the coronary arteries. That's why it's also given. Now, the drug of choice, which is nitroglycerine, it's it relieves pain within the next 1 to 5 minutes, so it can occur immediately. The relief from pain, and it is administered sublingually in tablet form. So we are going to instruct the patients to take nitroglycerine via the sublingual route. So it's a short-acting nitrate, and it's intended for short acute attacks of angina. Take note that the patient should carry the bottle or the container for nitroglycerin at all times. Just in case they feel chest pain that is related to angina, they can take it immediately for relief. And take note, we should teach the patient to store it or place it in a dark glass bottle, because nitroglycerin can be deactivated by light. So keep it away from light. And observe for its side effects such as headache, flushed face, dizziness, faintness, and tachycardia. These are common during the first few doses of the medication. And tell the patient, do not discontinue taking the drug. So this drug is going to be taken by the patient if the patient is experiencing chest pains associated to angina pectoris. So we are going to teach the patient that. What are they? To bring the drug with them at all times and take it as needed. Now, we are going to further teach them this. Nitroglycerin sublingual tablets are usually given in relief within the next 1 to 5 minutes. However, if pain is not relieved, we're going to teach the patient to use a second tablet after 5 minutes. So that second tablet is their second dose after taking the first tablet. But if the patient's chest pain is not yet relieved, we can give the third tablet. We can only give, or the patient can only take a total of 3. But after 5 minutes of taking the third tablet and the patient's chest pain is not yet relieved, we are going to tell the patient to contact his doctor immediately or call an ambulance, call the ER. That is one of our patient teachings because that is no longer MI. The patient is already suffering from myocardial infarction. I repeat, we can give 3 doses of nitroglycerin sublingually to a patient. If the patient's pain has not subsided within the next 5 minutes, give the second dose. After 5 minutes, the pain's still there, give the third dose. But if the pain is still there after 5 minutes or 5 minutes after giving the third dose, send the patient immediately to the hospital. That is already MI. Other drugs include beta adrenergic blockers. So assess pulse rate before administering the drug. Withhold if the patient is experiencing bradycardia and administer this with food to prevent GI upset. Examples are those drugs ending in olol, propranolol, inderal, atenolol, tenormin, and metoprolol, lopressor. Calcium channel blockers, those usually ending in dipin. Assess heart rate and blood pressure first before administering this drug. So give at least 1 hour before meals or 2 hours after meals for these drugs. Examples would be nifedipine, calci block, amlodipine, Norvasc, verapamil, isoptin, and diltiazem, cardizem. We also have antiplatelets. These drugs are taken as also as maintenance drugs of our patients. And examples of this would be aspirin. We advise to take we advise patients to take this drug together with food, since aspirin is a gastric irritant. It's made up of acid, and your stomach is also producing acid. So you mix acid with acid, it will further lower down the stomach's pH level, causing stomach or gastric upset. You also have other anticoagulants such as heparin sodium. This inactivates thrombin and other clotting factors, inhibiting the conversion of fibrinogen to fibrin, which is a stable clot. So once we are giving heparin sodium, we assess for signs and symptoms of bleeding and monitor the PTT or APTT levels. APTT is activated prothrombin time, or activation partial thromboplastin time, rather, sorry, because this is partial thromboplastin time. And always keep its antidote available, which is protamine sulfate. So if you see bleeding present, administer protamine sulfate once you see that. Warfarin sodium coumadin inhibits hepatic synthesis of vitamin K. So monitor the prothrombin time or INR and keep vitamin K available as well. Remember, when giving either heparin sodium or warfarin sodium, remember Harry Potter wears Calvin Klein. I've already mentioned to you that before. Harry Potter wears Calvin Klein. Harry Potter heparin protamine is the antidote. CK coumadin, K vitamin K is its antidote. That's why if the patient is taking in warfarin sodium for their um, for their angina or MI, you tell the patient to avoid foods that are rich in vitamin K, those green leafy vegetables, or else it will deactivate this drug. Okay, so that's very, very important to teach the patient. Other minimally invasive surgical procedures such as PTCA, percutaneous transluminal coronary angioplasty, directional coronary atherectomy or DCA, intracoronary stents or intravascular stenting, and laser ablation. I think I've already mentioned these surgical procedures before, together with cabbage and transmyocardial revascularization. So these minimally invasive surgical procedures, they are done through cardiac catheterization, while cabbage is done through open heart surgery. So nursing responsibilities here. Goals, number one goal is always to relieve the pain of the patient. Second is to return or restore coronary blood flow. And to prevent further attacks to reduce the risk of acute myocardial infarction. So that is our goal here. We teach the patient on how to take nitroglycerin in order for them to be relieved of pain and to return or restore coronary blood flow. They should avoid precipitating factors of angina, such as stress. They shouldn't be stressed. They shouldn't tire themselves. That's why rest is very, very important in patients who are suffering from angina. Their diet, we need to tell them to avoid foods that are high in salt and fat. So their diet should be low in sodium and fat and should be high in fiber, so that fiber will help eliminate bad cholesterol or low density lipoproteins from the body. Weight reduction and stress management technique is going to be done. So for weight reduction, especially if the patient is obese or overweight, they should watch out for their diet. They should remove carbs from their diet in order for them to lose their weight and avoid smoking, alcohol intake, and caffeine. Now we go to acute coronary syndrome and myocardial infarction. This is now the end result of having angina pectoris. Myocardial infarction is a coronary occlusion, also known as a heart attack. It is usually followed by sudden coronary occlusion and the abrupt cessation of blood flow to the myocardium. So if the blood vessel, most especially the coronary artery, is totally blocked, of course, blood is not going to flow through it, causing now MI to occur. It's considered as the endpoint for coronary artery disease. And there is a profound imbalance between oxygen supply and demand. And it is one of the leading causes of death in the world. It's one of the most common causes of death in the world. I've known several patients who died from this before, several acquaintances who died from this because of eating too much fat, for example. So etiology, it's brought about by coronary atherosclerosis or coronary artery disease, coronary occlusion by embolus or thrombus, coronary stenosis or spasms, or conditions that increase oxygen demand or decrease oxygen supply. Pathophysia, of course, same as that of CAD. There are changes in the coronary artery leading to inadequate coronary blood flow, especially if there's plaque formation. Myocardial ischemia can occur, or the zone of ischemia. Alterations in heart's function is going to occur. Wait, and it's not. There it goes. Autonomic responses leading to the exacerbation between oxygen supply and demand. Now, persistent ischemia results now to injury, which is a zone of injury. Further deprivation of blood supply would result necrosis of myocardial cells, which is a zone of infarction. So if there's no blood supplying the myocardium, of course, the muscle tissue is going to die. It's going to result to necrosis, leading now to the formation of a scar in the myocardium. And If that occurs, there will be permanent loss of myocardial contractility due to that scar formation, because that scar is not a new muscle that has been formed. It's a new tissue, but it doesn't do its job. It doesn't promote myocardial contractility. The common things that are happening here would be, of course, bring about the complications would brought about dysrhythmias, heart failure, pulmonary edema can occur. That's why for patients who have suffered from MI, you can see that they can have crackles, pink frothy sputum, dyspnea. There's cardiogenic shock that can occur. Pulmonary embolism can occur as well. Recurrent MI, ventricular aneurysm. So that's very, very difficult. Wherein the coronary arteries can suffer from aneurysm, which is abnormal dilation of the blood vessel. Pericarditis, mitral regurgitation can occur in sudden cardiac death. So as you can see here, this sample or an illustration of a heart that has undergone MI. As you can see, the lower portion of the left ventricle, it's pale. Sites of MI are the following: the anterior wall infarct. So the LADA is the one that is the one that is commonly occluded in MI. LADA, or left anterior descending artery. That's the coronary artery. We have the right coronary artery, posterior wall infarct. So if there's posterior wall infarct, the RCA or the circumflex artery is the one that is occluded. Inferior wall infarct, again, also the RCA. Classifications of MI. There's transmural infarct, so it extends from the endocardium to the epicardium. So transmural infarct involves the inner lining of the heart to the outer lining of the heart, while subendocardial infarct affects the endocardial muscles only. So it's the endocardium that is involved here. Intramural infarct, there are patchy areas of the myocardium and is associated with long-standing angina. So there are patches on the heart. Clinical manifestations, it's heavy crushing, knife-like, severe and prolonged chest pain, which is more than 30 minutes, which I've been mentioning it to you earlier. And it's not relieved by rest or nitroglycerin or any positional changes. That is why if the patient is not relieved for nitroglycerin after the third dose, they need to be sent to the hospital immediately. And there are feelings of doom or restlessness, feeling that they can or they are going to die, for example. Shock will occur due to cardiogenic shock. Oliguria, of course, there will be decreased urine output due to the inability of the heart to pump out blood into the rest of the arteries. Fever may occur. Indigestion and acute pulmonary edema may be associated with MI as well. Laboratory diagnostics, in the ECG, T-wave depression is seen in ischemia, while ST segment elevation, so you can see that the ST segment is elevated due to injury, and there's a pathologic Q wave. There shouldn't be a Q wave in the ECG. The Q wave should be normal together with the PQR, or the QRS rather, the QRS complex, QRS complex. Blood tests show that there's leukocytosis or increased WBCs and increased erythrocyte sedimentation rate, meaning there's an inflammation that is occurring, brought about by MI. So as you can see here, there is a depressed T wave, like what I've mentioned earlier, that's zone of ischemia. Look at the QRS segment. There's a pathologic Q wave there, and that shouldn't be the case. And the ST is elevated. It should not be elevated. It should be in line before the T wave is going to occur. So there, myocardial ischemia. There's not enough blood brought about by atherosclerosis or vasospasms, thrombosis, and embolism. Myocardial injury. So this one, the zone of infarction, as it's illustrated here. Cardiac markers, the CPK-MB. Onset is around 3 to 6 hours. Wait. So the creatine phosphokinase, my is onset is around 3 to 6 hours. Peak is around 12 to 18 hours, and the normal duration is around 3 to 4 days. So for this, you always need to know the creatine phosphokinase myocardial band. Onset is 3 to 6 hours, peak to 12 to 18 hours, and the duration is around 3 to 4 days. LDH or lactate dehydrogenase is also present. Troponin 1 and T is also present. Onset is around 7 to 14 hours. Normal is around, or the normal duration is present around 5 to 7 days together with myoglobin. Remember, if these enzymes are present, CPK-MB, LDH, troponin, and myoglobin, it means that the patient is suffering from MI. These are the cardiac markers. Medical management. Minimize myocardial damage, preserve myocardial function, and prevent complication. And it's very, very important to learn about MONA. Morphine, oxygen, nitroglycerin, and the aspirin. Or the MONA task for the immediate treatment of myocardial infarction. Remember MONA tasks. MONA M stands for morphine. It's an analgesic that will help relieve the pain and anxiety of the patient. And since it's a vasodilator, it will help improve the flow of blood into the myocardium. And also will decrease the workload of the heart by reducing preload and the afterload. Oxygen is very, very important as well to provide and improve oxygenation of ischemic myocardial tissue enforced together with bed rest to help reduce myocardial oxygen consumption. And it's given by nasal cannula for about 2 to 4 liters per minute. Nitroglycerin, we've already mentioned that before. It's for the first line treatment of angina pectoris. Aspirin. This will help help reduce the formation or prevent the formation of thromboxane A2, which causes platelets to aggregate and arteries to constrict. So, patients who are having angina should have or should take this daily to prevent blood clots to form. Thrombolytics. Thrombolytics such as alteplase can be given. This will dissolve the thrombus and coronary arteries, allowing the blood to flow through again, minimizing the size of infarction and preserving ventricular function. And it's given in some patients who have MI. So thrombolytics are very, very important to give to patients. So example of these are retiplase, alteplase, those drugs ending in place. These are examples of thrombolytics. It will help dissolve blood clot. Anticoagulants, I've already mentioned heparin and warfarin. You all well know about that. Stool softeners, high fiber diet in order for them to pass out stools or to have a proper bowel movement. Remember, for patients who are suffering from MI, they should not do the Valsalva maneuver, or else they will intense straining during defecation. or during bowel movement may trigger arrhythmias and another cardiac arrest. So give them stall softeners, such as laxatives, or it's better if the patient will take a high fiber diet. Sedatives. So in order to limit the size of infarction and give the rest to the patient, Valium or an equivalent is usually given. Diazepam, alprazolam, and the others ending am or lam, they are given to these patients in order as well to reduce the activity of the patient. Myocardial infarction medical management. Infarctions. Remember infarctions. IV access to IV lines are placed usually to ensure that access is available for administering emergency medications. Narcotic analgesics, we've mentioned that earlier, which is morphine given. Facilities for defibrillation, just in case the patient undergoes cardiac arrest, have a defibrillator available. Unfortunately, here in the Philippines, it's not readily available in some public hospitals. Maybe in St. Luke's, or most probably in St. Luke's and Makati Medical Center, these defibrillators are available. But the local hospitals that we have here in Pangasinan, we don't have them. Aspirin, we've mentioned that. Bed rest is very, very important for patients who have MI. We should not tire our patients. Promote bed rest and healing. Converting enzyme inhibitors. The ACE inhibitors are very, very helpful in order to control the blood pressure of the patient and for the kidneys to excrete sodium and fluids. That's why we give them ACE inhibitors such as captopril, enalapril, those ending in pril, those are our ACE inhibitors. Thrombolytics, I've already mentioned them, the place drugs. IV beta blockers, I've mentioned them earlier, propranolol, atenolol, and the other olols. Oxygen, I've mentioned that earlier, nitrates, nitroglycerin, stool softeners. So we've already mentioned those. Nursing management, activate EMS and start a code if the patient experiences MI or even cardiac arrest. So we need to inform the rest of the staff on what is happening to the patient. So by activating our emergency medical services, the rest of the staff will go to the patient's room together with the doctor. Implement CBR, complete bed rest without bathroom privileges as ordered. So there are no bathroom privileges for the meantime. Allay anxiety, tell the family members not to emotionally stress the patient, and identify signs and symptoms of heart failure and other complications. Cardiac rehabilitation will happen. There are 4 phases. I'm going to assign that to you as a homework. What are the 4 phases of cardiac rehab in order to promote self-care and independence? Health teachings, you emphasize lifelong lifestyle modifications. Of course, they should do proper dieting, avoid salty and fatty foods. And once they resume activities of daily living, we can we can slowly assist them in the activities of daily living until they eventually independently do their own activities of daily living. What else? When can they do, let's say, for example, um, for this is a common NCLEX question. If the patient is able to climb up the stairs of their house independently, that's the time that they are allowed to do certain exercises. Also, they are allowed to engage in sexual intercourse with their spouse. Again, I repeat, as long as the patient is able to independently go up the stairs without any assist at all, that's the time they can do exercises, and engage in sexual intercourse. So if you have any more questions with regards to our topic about angina and myocardial infarction, just send me a message. I would be gladly assisting you with your questions. And thank you very much again for attending today's class in cardio. Enjoy the rest of your weekend and have a great day. Thank you. Bye bye.